Hi, I'm Mark Houston, the usual host of Doc Talk. Today, I'm here just to introduce this special live episode recorded at the Matthews Opera House in Spearfish. The National Sleep Foundation estimates that 936 million adults worldwide live with obstructive sleep apnea, including about 30 million in the United States. To help us better understand this condition, Doc Talk Live features Dr. Loren Jones, an ear, nose, and throat surgeon at Monument Health. With more than 13 years of experience, Dr. Jones will highlight treatment options for sleep apnea and spotlight the Inspire procedure, a groundbreaking therapy that's changing lives as an alternative to C-PAP machines. If you're new to the show, Doc Talk is a weekly podcast where we bring you real conversations with medical experts on the topics that matter most to your health. You can find new episodes every Tuesday wherever you get your podcasts. Now, here's Doc Talk Live with Dr. Loren Jones.
Hi, everybody. Thanks for coming. Loren Jones, Spearfish native, been here back with Monument since 2014, so it's good to be back home and taking care of people where I'm from. So just a little introduction to sleep apnea by way of priming the conversation. Like Nick said, it's very prevalent. A lot of people have it. And I think it's probably undertreated, underdiagnosed to a significant degree because people are kind of down on C-PAP and don't even want to go get checked for fear of getting told they have to wear that ugly mask and don't want to do it. But sleep apnea is really, we're talking about obstructive sleep apnea. There's central sleep apnea, which is a different problem. But obstructive sleep apnea happens in your throat between the level of your palate and your voice box, where the tongue, the tonsils, the side walls of the throat, the epiglottis above the vocal cords themselves all can get kind of relaxed when you go to sleep. And with you laying backwards and no muscle tone, the tissues fall back and start to block the airway. And when you're trying to breathe in, it can make a little negative pressure and pull that airway shut and air doesn't flow. It can affect the exhaling too. But in any case, your throat closes when you're breathing and you don't get air into your lungs and you don't get oxygen into your bloodstream. Eventually, your brain discovers this and says, oh, the oxygen level's dropping, we better do something about that. And it, without waking you generally, arouses enough to send some muscle tone back down to your throat. And there's two main problems with this. One is long-term risk to your cardiovascular health. It is hard on your heart to have those repeated periods, not only of negative pressure in the chest from trying to pull against an obstruction, but also oxygen levels dropping. So that's hard on your cardiovascular system and increases risk of cardiovascular events and strokes. And then it's also very disruptive to your sleep. You might not wake up, but you don't get restful sleep. You need to go through the whole cycle of the sleep stages a couple of times a night to get a fully restful night's sleep. And sleep apnea severely disrupts that and causes people to have troubles.
Does anybody from the crowd have any questions so far? Excellent. So, Dr. Jones, if you could, can someone have sleep apnea if they're not overweight or they don't snore loudly?
Sure. Definitely people who have a normal body weight can have sleep apnea. That's not uncommon. It's increased body weight does increase the risk because there's more soft tissue fullness in the tissues around the airway and more pressure pushing on your chest for breathing effort as well sometimes. But normal body weight people can certainly have sleep apnea. And as far as snoring goes, not everybody will have loud snoring that has sleep apnea, although most people that have sleep apnea will snore to some extent.
And how dangerous would you say untreated sleep apnea would be in the long run?
Depends on the severity. So the diagnosis of sleep apnea, if any of y'all have had sleep studies, probably a lot of you have, is boiled down to one basic number. If you had to take it away from your sleep study, called the apnea-hypopnea index. And if that's arbitrarily, there's kind of a line drawn at 5 events per hour where your oxygen levels drop. And if you had 5 or 6 events per hour or 7, that's pretty mild sleep apnea. It's probably not really a huge long-term cardiovascular risk. But if you have 30 or 50 or 70 or 120 events per hour, that's very, very hard on you. And it's very high risk of causing right-sided heart failure, long-term risk of, other coronary diseases.
What would you say are some of the lesser known symptoms of sleep apnea that people often overlook?
Signs more than symptoms. The one symptom people may not realize is a morning headache. So if you get a headache in the morning, most days, that's pretty good chance you might have sleep apnea that's causing that. A wake-up headache is a big one. People can grind their teeth during sleep. There's the snoring. There's obviously daytime sleepiness that people can have to a larger or lesser extent. Yes, ma'am.
I don't snore and I don't grind my teeth. I don't like to talk in those. But I do have nightmares and I go into AFib.
You go in and out of AFib on your own. Yeah, nightmares certainly, and some other parasomnias can be signs of sleep apnea. I think they're a little more common in children, but they can be in adults too. As far as the AFib, certainly the sorts of things that prolonged untreated sleep apnea can do to your heart can predispose you to AFib. They put a lot of strain on the right side of the heart, which can put that part of the heart that controls the rhythm under stress. First best thing to do is to get a sleep study to understand. So just to explain what Inspire is real quick and the basic ways people could become a candidate for Inspire. Inspire is a therapy that involves no hoses, masks, nothing external. It's not to do with pushing airflow in. It's to do with supporting the musculature of your airway so that it doesn't collapse and allows the air to flow in a natural way. And what it amounts to is the nerve that moves your tongue, called the hypoglossal nerve, gets some electrodes put around it. And those wires from the electrodes go down to a thing in your chest. This is a mock-up of it that goes in your upper chest, just like a pacemaker would on the left side, usually for cardiac stuff. Inspire's on the right, typically. And then after you're all healed up, the device gets activated at a post-op visit. And over the first couple of months of use, the device gets adjusted as far as how much stimulus level it's applying to that nerve to find the right level for you. And then after a few months, they typically do a sleep study with the device on to make sure it's effective. You turn it on with a remote control when you go to sleep. It waits a little while, usually half an hour is the default. It could be adjusted though. And then it comes on and starts every time you breathe in, and the timing of when it sends its stimulus can be adjusted if needed to. But in every breath in, it sends electricity to that nerve and makes your tongue push forward a little bit. And that keeps your airway open. Well, that's part of the titration process. So if you turned the thing up to its maximum, yeah, you'd feel it. Your tongue would come out of your mouth. And when we're testing them in the OR to make sure they're working, that's what we look for, is to see the tongue stick out to verify that the device is working as it should before we, close up the surgery. But in any case, the titration process starts at a low level of electricity applied, and gradually with the remote, a little bit at a time, every week or every few days, whatever you and your person doing the titration with you talk about, you gradually increase the levels. And they believe there's 10 settings on the remote, and you go up a little, up a little, up a little, until, oh man, that's maybe starting to feel it, or it's starting to help me not stay asleep as well as I'd like to because I feel it. Then you go back a notch and kind of find the right level there and make sure with the sleep study afterwards that it's actually an effective stimulus level for you and that it's comfortable. Why do you have to use a CPAP first? The FDA says you have to, so we can't implant these in somebody who's not CPAP intolerant. So the basic criteria for Inspire are you have obstructive sleep apnea with a severity, the apnea-hypopnea index I talked about, between 15 at the low end and 100. So that's mild to very severe sleep apnea, or moderate to very severe sleep apnea. If you have mild sleep apnea, you're not a candidate. If you have over 100 events per hour, really, really severe case, not a candidate. The second criteria is body mass index has to be under 40, according to the FDA. Insurance companies, some of them don't go up to 40. So they have different numbers, 38, 35, even 32 for some of them. So that's the second hard criteria. AHI and BMI are pretty hard criteria. CPAP intolerance is the third criteria. I don't tolerate CPAP. And that is not specifically and rigidly defined. It's not like you have to have worn CPAP for 3 months and you come see Kayla or somebody like her, and the download of your machine says you've only used X% of the number of hours of sleep, and so you're CPAP intolerant, and therefore you can look at Inspire. It's more subjective than that. And the talk I like to have with patients about that is CPAP is overall, if it's worn all the time, a more effective therapy than Inspire because it treats all the possible levels of collapse. So you can have collapse up by your palate that Inspire won't treat, and we have to check for that before we can implant Inspire. It treats very well the lower throat collapse, but it doesn't treat all the areas. And so if you had to choose and you felt like, okay, I can tolerate either one, CPAP probably is marginally more effective if a patient wears it all the time. If you wear a CPAP 4 hours a night, 5 nights a week, but you would use Inspire 6.5 hours a night, 7 nights a week, even though the AHI reduction is a little less probably with Inspire, I think overall you're probably getting more effective therapy with Inspire. So do you have to wear a CPAP? No, but you probably have to take a prescription for one home and say you tried it. You're having your sleep study tonight. Okay, well, because we'll know more tomorrow. Typically, if you're prescribed a CPAP, their time horizon in sleep medicine on seeing you back after being prescribed a CPAP is probably more like 3 to 6 months to see how you're doing with it. And if you have it at home in the closet for all that time and you say, man, I put it on my face and I go claustrophobic and I just can't wear the thing, we're not here to say no. You don't have to, but we do think that it's best for the patient to at least give it a try with an open mind. And if you're like, man, that just isn't for me, that's okay. But it is something that, according to the guidelines, which we want to follow the guidelines, we don't want to color outside the lines, you have to at least try it at some level, which entails taking it home. And I think 30 days would be a bare minimum of trying it at home. And that's probably even a little on the low side. You agree, Kayla?
Is there a sleep study place local here?
Yeah, so Monument does sleep studies here in Spearfish, and we can do home sleep studies a couple of ways. Home sleep tests can be done through sleep medicine with Monument, which you would come into the home medical equipment store and they'd fit you for the equipment. You'd wear it home. You'd bring it back the next day. There's also mail order home sleep tests. And not that I'm trying to steal business from Monument Sleep, but there's a company that provides home sleep tests that provides a discount to patients who are considering Inspire, but is no insurance involved. It's $140 out of pocket, but it happens pretty quick. That's one of the advantages to that method. And we have that information in my office. Yes, sir.
We found out the hard way that Medicare does not pay for a home sleep study. They don't recognize it. You actually have to go in to a facility and have the sleep study. That's the only thing Medicare recognizes.
Depends on the type of home sleep test and probably on the diagnoses that were applied to get authorization for it. But certain home sleep tests have to have enough channels of monitoring to qualify for Medicare. And like the one I was talking about that we can have mail ordered for $140 probably wouldn't be paid for by Medicare, but that's why they dropped the cost fairly reasonable, and it meets the criteria for assessing for sleep apnea for something like Inspire, though. I'm sorry you found out the hard way, though.
If it's working properly, the Inspire, you don't even know that you're not waking up and it kicks in during the night or something. You don't even know it's there working properly.
Correct. Most patients should be able to reach a level where the stimulus is adequate to very effectively treat their sleep apnea, but you don't know, you're not aware of it. That's why it waits a little while before it turns on to let you fall asleep. And there's a function in it if you wake up in the middle of the night to go to the bathroom or something. You push a button and it pauses it for a few minutes and lets you fall back asleep. I've had people that have come back into the office that swore there was something wrong with the implant, there was something wrong with their voice, this, that, or the other. And they're like, well, did you turn it off? And they thought they had, but they hadn't. So, but they didn't know, like, they didn't feel like, man, my tongue. So it's pretty subtle when it's working at an appropriate level.
Does it mean side your stomach? That?
It doesn't make a difference for Inspire. A lot of people's sleep apnea is worse when you're on your back, just because gravity pulls the tongue back more in that position. So when you read a full in-hospital sleep study, it'll characterize how bad the sleep apnea was on your back versus on your side versus if you do lay on your stomach at all, which a lot of people don't. But it'll show those differences in the sleep study, but it doesn't change the efficacy of Inspire. It's probably, on the back is the worst case scenario, and that's probably kind of what we titrate for. The tolerance on it is around 90% of people, and some of them with a few, periods of adjustment in the process, and some of them just like slick. It works, super great right off the bat, but a small number of people require a little bit of fine tuning and stuff to get to the right spot. But about 90% of people become effective at tolerating and getting C-PAP treatment, every night with Inspire versus C-PAP is probably in the high 60s, like maybe a little more. Yes, sir.
I think if I understand right, what you're saying is that if you have been using CPAP for a period of time, you're probably not eligible for that. Because let's face it, everybody's strong.
Right. Yeah, I wear a CPAP too. I don't like it. I wear it every night. I tolerate it. I'm not planning to go see some other doctor, not me, and try to get an Inspire. It's as nice as it would be to think of not wearing the CPAP. Currently, that's not the guidelines. And so I think if you were finding a surgeon that would do stuff that's not on the FDA indications for the device, you'd probably not be in a good place. So yeah. So yeah, if you wear a CPAP every night and you hate it, but you wear it and sleep well, and you go to your sleep provider and they download your device and it says, 93% of nights you're wearing it over 6 hours or over 4 hours, whatever they're looking at, then yeah, you're probably best off just sticking with CPAP in that situation.
Some of the regulation is it take a 2-hour nap in the afternoon. It's just like going to sleep. I mean, Inspire is working in as well.
You have to turn it on. So you have a remote, and Morgan has some foam models of the remote over there, but it's a remote that you get the day of surgery. They send it home with you, and the device is sort of externally deactivated for the first 30 days until you come to your post-visit. But yeah, you turn it on every night. If you wanted to take a nap, you can turn it on for that. Somebody else was just asking beforehand, well, I'd take a nap in my recliner at lunchtime for an hour or something, but the CPAP's in the bedroom. I can't wear it for that. And yeah, it could make that sleep more peaceful for you with Inspire versus CPAP if you nap somewhere else.
Can you tell us what your patients say after getting Inspire? I mean, what's their reaction or what's their experience? I'm sure you talk to it.
And Kayla and or Jeanette can probably talk about that more. I see them post-op for the surgical part, and then the titration and getting used to the device is in the hands a lot of sleep medicine professionals like Kayla. Jeanette's doing some of those visits as well. And then the representatives from the company, Morgan and her new partner, Heather, are very hands-on. Inspire wants to make sure all their patients are effectively treated. So if somebody's having an issue where something needs to be adjusted, they are very proactive at making sure that we find out what the issue is and getting it straightened out. But most people I've talked to, months after are very much in the camp of, hey, this is great. I love it. Use it every night. And it's a good solution for most of the people that meet the criteria to get it in the first place.
I guess one thing that I think patients are quite ready for. I'm Jeanette, by the way. Dr. Jones is a nurse practitioner, and I do a lot of the post-op. You are going to be sore afterwards. It's tender. Your neck is going to be really sore. So I think that's one thing that, we've been trying to prepare patients for, but I just don't, until you go through it, you don't realize it. We also there are some weight restrictions. So for the first week afterwards, we don't want you lifting anything heavier than 5 pounds for the first week. And then after 2 weeks, we'll increase that to 10 pounds. No more restrictions after a month, but I think that's just something to kind of, let you know about. And then as far as physical activity, we don't want you doing anything more than walking because it is sore and you are going to be tender. But once patients get through that first month, they're pretty excited and we get those devices turned on and they're pretty happy with how they're sleeping and how much better they feel because they are getting a better night's rest. And Kayla does more of like the sleep medicine side of it. Patients so far are happy with it. And I tell them, I want to see you back in 4 months, but if you feel like it's a waste of time and you don't need to see me back, cancel the appointment. And I've had none of my patients have come back at 4 months saying that they're concerned. So, and we've been doing this for about 18 months now.
Yeah, getting close to that. Yep.
Yeah. So we have really good results and our patients are happy with it.
How long does it last?
The battery is predicted to last 11 years. Is that the same for the new implant too, Morgan? Yeah. Sir.
Do you still wear the CPAP for the first 30 days after we're in?
Well, yeah. I mean, if you were CPAP intolerant and you were getting it on for, 4 hours, 5 nights a week or something, probably still worth the effort to try to wear it those first 30 nights. I will say that, a side comment, the most surprising thing I've seen since doing Inspire is sometimes if people need a little bit of a tune-up on what's going on with the device, we do what's called an awake endoscopy, where in the clinic I look with a little tiny scope through the nose down at the throat, and then Morgan or one of the other reps will turn on the device while we're looking and see which stimulus patterns work best. And it opens your airway. It is impressive how much airway opening it gets, even in an awake upright patient who already has their airway open. So it's very effective.
It's an outpatient.
Yeah, surgery. So a couple of things. We talked about the 3 requirements. The sleep apnea, moderate to severe, the BMI requirement under 40, C-PAP intolerance. We also have to do a thing called a drug-induced sleep endoscopy, which means you go to sleep in the operating room, not with a breathing tube in your throat, just a little bit of IV medicine, very light anesthesia to mimic natural sleep as close as we can with drugs. Yeah, we get to the point where you don't respond to verbal stimuli and you don't wince if I put a scope in your nose, and that's all the sleepier we get you. And we watch your throat with the camera in your nose to make sure that you're not having that collapse at the palate level. If your palate is completely collapsing, then we know Inspire probably is not going to be that effective for you. And about 80 or 85% of people who have the sleep endoscopy are candidates for Inspire, but there's some where the levels of collapse don't match with Inspire and we have to not proceed. So that's just a very quick 5 minutes of anesthesia. You go home and don't have much hangover from anesthesia or anything. The day of the surgery for an implant is around 2 hours of surgery to put the implant in, because it's pretty delicate dissection around that nerve. And the nerve that moves your tongue has branches that push your tongue backwards and branches that push your tongue forwards. And I have to separate out those parts and put the electrode array in the little tiny space between them. So it's delicate surgery done with magnification up here. The part in the chest is a little less delicate. But in any case, about 2 hour operation, go home the same day. And like Jeanette said, you're pretty sore the first week, and we need you to be fairly restricted with that right upper extremity for the first month, because we have to go currently through your pectoralis muscle and divide the fibers of that muscle to get a sensor down between your ribs to tell when you're breathing. They have a new implant coming out. It's out. I don't know if any been done in Rapid yet. We haven't done any here. There've been some that does not require us to go through the pec muscle. It's just all subcutaneous in the chest. So it's probably a little less painful and restrictive with the chest stuff with the new implant.
So the one you have now is in the muscle.
This thing sits above the muscle, but a lead from this goes through the muscle and between the ribs to sense when you breathe. The new one has an accelerometer in it that senses the breathing by motion rather than by sensing pressure of the rib cage.
Is that Medicare eligible usually?
Yeah, Medicare covers it. I don't think there's any payers that don't cover, right, Morgan? They may have various restrictions on body mass index and so forth, but they all cover the procedure.
What have been some of the long-term outcomes that you've seen from people that have used this for multiple years?
So I've only been implanting for 18 months, so I don't know about multiple years. I have to rely on the data, which Inspire has some graphs of back there, but vast majority of patients tolerate it, about 90%. And what I was talking about earlier about the reduction of AHI, I think Inspire puts forward a number of about 79% reduction in your apnea-hypopnea index, where C-PAP, if you can tolerate it, might reduce it 95%. But what I've been saying to patients for a long time is if you have a 95% solution you can't use, or can only use 30% of the time, and you have a 75 or 80% solution that you can use all the time, that's clearly the one that works better for you.
Is there any restriction as far as fitness or something? I mean, you still go fitness center, Fred pickleball, or...
Oh yeah, that's all fine. After that first month, when we want you to restrict that, like we've had to tell people, hey, you're going to have to knock off your golf this first month because you can't swing that golf club very well. Otherwise, no. Kayla has a couple things she wanted to add real quick, if that's okay.
So as Dr. Jones said, I'm PA, I work in sleep medicine. And so I kind of see patients after ENT has done the implant. And so I just wanted to let you know, like the process as far as follow-ups and things. If you use a CPAP, we do CPAP frequently. And so same with Inspire. Like we said, we give you time to heal from the surgery. Have you come in, we actually activate the device. So we decide with the rep usually what settings are appropriate to start at. And then we kind of slowly have you increase over time as tolerated. And then we do see you back multiple times within our office to kind of check in to see if you're tolerating the device, what settings you're on currently. If you aren't tolerating it or you are having some trouble getting used to it, there's some, fine-tune adjustments we can make and things. And so we do see you back several times to sort of see how things are going. If you're doing really well with it, you're using it, you're feeling great. We do have you do a fine-tune sleep study is what it's called. And so in comparison to the CPAP machine gives a lot of your nightly apneic episodes. It tells you how you're breathing with the machine. The Inspire does not give us those nightly numbers. And so what we do is we have you do a fine-tuned sleep study to ensure that your settings are working appropriately. So during that fine-tuned study, that's an in-lab study. The sleep tech will make some adjustments if needed to make sure that the device is working appropriately. Otherwise, we go off of subjective, how you're feeling, but we like to do that fine-tune to see how things are going number-wise as well. And then typically once everything you're doing well with it and you're happy with it and it's working and you're tolerating it, we do see you back about every 6 months to a year just to kind of check. Sometimes people have weight changes or different things and they will need some adjustments on the device. But yeah, that's kind of the follow-up from the sleep medicine standpoint after kind of for the long term. Question?
So if a patient is on oxygen, what does Inspire? Do you have to have oxygen and nasal oxygen?
If you were on nocturnal oxygen plus C-PAP and you wanted to use Inspire to get off the C-PAP, you still need the oxygen.
She mentioned a change in weight. So weight change it and he has the device. What's that from it is?
So weight generally is proportional to OSA severity at some degree. It's not a linear correlation by any stretch. So if you gained a lot of weight after getting implanted, the control of your sleep apnea might be slightly decreased. Within the range of a BMI up to 40, the FDA indication, there's good data to say that it works very well. And it probably works well even for people heavier than that. But the data wasn't there for the FDA to approve that. But so if you gained weight, it's still going to work. Possibly it might be that your sleep apnea gets a little worse as, proportionally, it's going to still probably decrease you by about the same amount. So if your sleep apnea gets worse when you're heavier, the absolute numbers might go up, but the level of relative control you get shouldn't change a lot.
And so kind of from a next steps perspective, Dr. Jones, if people say tomorrow they wake up after kind of digesting this conversation, they want to talk to their primary care provider about Inspire or maybe other options. Maybe they're just at square one. Maybe they've found they've been snoring at night. They're wanting to take those first steps into making sure that they're taking care of their health. What are your recommendations on bringing up those concerns with their primary care provider?
Yeah, I think it's very simple. Just say, hey, my spouse says I'm snoring. I've noticed I'm snoring, or I'm concerned about sleep apnea, or my Apple Watch or my Oura Ring says my oxygen levels are dropping at night. What do we need to do about that? And I will say further that we at the ENT clinic here in Spearfish want to have a very open door policy to get in with Jeanette or I or with Kayla. She's going to start having some more availability here in Spearfish to just come to us directly if you don't have a good established relationship with a primary care provider, or it's difficult to get scheduled and you're going to wait 6 weeks to see them and then 6 or 8 weeks to see us, and you just want to cut out the middleman, we're happy to kind of just start from the beginning and sort things out, see where you stand, see if we need a new sleep study. That's the other thing. Sleep studies have to be less than 2 years old for Inspire. So if you had a sleep study 8 years ago and you threw your CPAP away 7 years ago, and you'd have to start with a new sleep study.
Sleep study is about, there's all these.
Right. So the in-lab ones are the best. They're the gold standard. All the others measure themselves by in-lab polysomnography with multiple channels they monitor respiratory effort, they monitor airflow, they monitor pulse ox, they monitor brain waves, they monitor for leg movements during sleep, all kinds of things. And there's video, and there's a sleep tech watching the study. And if in the first half of the study you're found to have sleep apnea, they'll try you on a CPAP the second half and find out what pressure you need. So those are some of the advantages of in-lab studies. Home studies, there's a wide variety of how much monitoring they do. The one that I told you about that's like mail order for $140 with no insurance is the bare minimum level of monitoring. The sleep studies that you would get, like if I ordered you a home sleep test through Monument and you went to a Monument sleep lab through the DME store here, they monitor more than a very basic home sleep test through the mail order, but not as much as an in-lab one. They all can give us the basic data we need. For complex cases, though, the in-lab one definitely has some advantages.